Next, we have Suzanne Lenzsch, the director of the Multiple Myeloma and Amyloidosis Program from Columbia University in New York City. She's going to be talking to us about a recent advance in the anti-plasma cell treatment of AL amyloidosis, specifically monoclonal antibodies. Thanks so much.
I would like to start and thank Jeff Zonder and Silva Prager for organizing a fantastic meeting. They did really a great job. They did that all on themselves, without a company or anything. I think it's amazing. It's a lot of work to do this, and thank you for this, really. I also wanted to kind of, suggest that we should consider to have this meeting much more often. I think amyloidosis is a rare disease because we make it rare. Consider that 15% of the myeloma patients have overlapping amyloidosis, so we really should raise more awareness, and this is one of the meetings that helps us to raise awareness. So thank you, Silva and Jeff, so much for doing this. So as expected, let me start with my disclosures. I especially want to point out that I will talk about monoclonal antibodies, Daratumumab, Elotuzumab, Rituximab as an off-label use. And I would like to start my presentation with my most favorite slide from Angela. I hope she is here and sees this. It nicely describes the principles of the treatment of amyloidosis. So in AL amyloidosis, it's most important to induce a hematologic response. You want to eradicate plasma cells and completely shut off the production of free light chains in order to allow the body to break down amyloid fibrils or stop the amyloid fibril production. That's why in the treatment, we really go for a complete response, or at least the VGPR. Keep in mind, and Giovanni mentioned that already, the VGPR is characterized, and I really want to repeat this, by the difference of the kappa and lambda light chains should be less than 4 milligram per deciliter or 40 milligram per liter, depending on the units you have, don't mix this. The responses, the hematologic responses, should be durable in order to allow an organ response, because only with a durable hematologic response, the body is able to break down amyloid deposits and allow an organ recovery, finally, with an improvement of the overall survival. And this is a slide work from Dr. Matka from the Mayo Clinic. He analyzed 1,500 patients according to the time when they were diagnosed. And you can see that patients who were diagnosed after 2005 had an increase in their 2-year overall survival from 25 to around 50%. But what you still see is that there's an early high mortality. We lose around 50% of the patients in the first 2 years, and still 40% of the patients in the first year from their diagnosis when they are not transplant eligible. And this is 80% of the treatment population. What Dr. Mukta also analyzed was how do we treat those patients? And you can see that there's an increased use of bortezomib in transplant eligible patients. Around 60% of the transplant-eligible patients still do not get any induction therapy in the gray area. You can see that here. And then we look for the patients who undergo transplant, an autologous stem cell transplant. Most of the patients receive Cybo-D, cyclophosphamide, bortezomib, and dexamethasone, around 65% of the patients. So the majority of patients receives their treatments. It's working very well, and most of us use combination of bortezomib based on a work from Joe Mikhail. He published that in Blood 2012 and showed a stunning overall response rate of 94% with a complete response rate of 71%. Even if we don't reach that response rate in our practice, we implemented bortezomib in our treatment. And right now, as you can see here on that nice overview from Dr. Merlini, bortezomib is included in different combinations, and Giovanni also pointed that out with melphalan and dex and also with cyclophosphamide, and I would say it's the main treatment for us. But nevertheless, what you see is also in this work from Dr. Palladini that the early mortality is still a problem. You see that the complete response rate tripled from 15% to over 40%. That is kind of in a huge step into the right direction. But what you also see is that the early mortality is still unchanged. So we haven't made any progress in the early mortality. This was also pointed out by the work of Dr. Mukta, which I cited already, that you can see the 6 months overall mortality has not really changed, even if we added bortezomib. So what can we do to overcome that problem and really improve the overall survival? Well, there are two things. We can help the body to break down the amyloid, and I think there is a lot of excitement over the last 10 years to use monoclonal antibodies like NeoD001, which has failed in clinical trials, or the GSK antibody, but unfortunately the development was discontinued. I think Dr. Sonder will talk later about this. We have KIL-101, and hopefully it will deliver what it promised based on very, I would say, promising data from a phase 1A clinical trial. And we have doxycycline, and I think Dr. Wetschlacker will talk later about this. So we can directly target amyloid, but right now we really don't have, I would say, very viable options available to everybody. So what is left is we can further try to induce sustained and deeper responses, really long-term responses, and responses that act very fast. If most of the patients, or 40%, die within the first 12 months, you don't have a lot of time to try a lot of chemotherapies which will reduce your plasma cell clone. So I don't want to elaborate too much on Daratumumab. You probably heard often about the mechanism of Daratumumab. It's approved in multiple myeloma, but just to kind of recall the principal mechanism, it's a humanized monoclonal antibody that binds to CD38, and it mediates its anti-plasma cell effects via complement-dependent cytotoxicity and antibody-dependent cytotoxicity. Also, it induces phagocytosis by macrophages. This is something we sometimes under-evaluate in cancer therapy, and it induces directly apoptosis. You are all aware about a large trial with 700 patients that was performed in Europe. It included or randomized newly diagnosed multiple myeloma patients. Patients were randomized to Velcade, melphalan, and prednisone, or to Daratumumab, Velcade, melphalan, prednisone, and the results were really stunning. So 71% of the patients had a VGPR, and almost 50% a complete remission. This is an unheard result and was significantly better in comparison when patients were only treated with Velcade, melphalan, and prednisone. So based on this, we started to use Daratumumab in AL amyloidosis, and here Dr. Kaufman from Dr. Littke's center in Stanford was the first group that published retrospective experiences with 25 patients, AL amyloid patients previously treated, and they treat the patients according to the myeloma schedule. The patients were heavily pretreated but had a very nice overall hematologic response rate of 76%, with a complete response rate of 36 and a VGPR of 21. This was very encouraging, and what was also encouraging was the response time occurred within the first month. The treatment was very well tolerated, and this is important. Even in patients with cardiac amyloidosis, it was tolerated, and the grade 1-2 infusions occurred as expected in more than half of the patients, but they didn't see higher grade 3-4 infusion reactions. You can see here the response rate according to my color vision. The purple and the blue patients are the ones with a complete and with a very good partial remission, and you can see that the majority of the patients really underwent a VGPR and a CR. This is, I think, very impressive, and it demonstrates how fast patients respond. You can see here are 3 patients, and this is the involved light chain clone, and you can see when patients receive Daratumumab, how fast within less than a month, the free light chains are reduced. I think this is what we need in AL amyloidosis, a fast resolution or decrease of the light chain clone. This is a work by Dr. Sanchurawala, which she presented at the ISA meeting in Kumamoto this year. So she showed in 18 patients how fast also Daratumumab is responding. This is the hematologic response after 1 month, and in blue you can see all the patients that achieved a partial or very good partial response. You can see that most of the patients had a dramatic decrease here, over 90% during the first months of the treatment. Also in her study, the adverse events were the drug was very well tolerated. They didn't experience any higher grade 3-4 infusion-related reactions, and the severe adverse events occurred in patients with respiratory problems. This is a work, and I would like to draw your attention to an abstract that will be presented here at ASH from Dr. Rahman, who summarized the current experience of the efficacy and tolerability of Daratumumab in heavily pretreated amyloid patients. What you can also see, despite the numbers are limited in those studies, what you see is that always over 50% of the patients achieved the response goal with a complete or remission or a VGPR. Another work by the Mayo Clinic compared Daratumumab in monotherapy or in combination therapy and the outcome. And again, you can see that even as a monotherapy, also in combination, the response rate are around 80%, very high, including CRs and VGPRs. But what is also important is when you look for the median follow-up of this study, it's almost a year. In this year, none of the progression-free survival and also the overall survival was not reached, reflecting that this drug kind of really induces long-term remissions, what we also need in the treatment for amyloidosis. Again, the drug was as monotherapy, also in combination very well tolerated. I would like to point out here that neutropenia grade 3 and even 4 can be seen in combination, and I would like to really raise your attention when you combine Daratumumab with especially IMiDs, Revlimid, you can see higher grade neutropenias grade 3, 4, up to 0 neutrophils that happened with my patients. And in the beginning, as we started to use Daratumumab, it was quite a surprise in some of the patients. Easily to manage when you give growth factors to these patients. A problem that is associated with Daratumumab is the long infusion time, and this is a work from Dr. Wetschlacker in which he compared or showed the infusion time in patients with AL amyloidosis. It's already high in patients with multiple myeloma, but again, in AL amyloidosis, we try to be even more careful and give infusions, fearing the infusion reactions a little bit more gentle. So infusion time was up to over 10 hours, which is, I think, on a larger patient population base, really not doable. So that's why Janssen came up with the idea, and I think it's a brilliant solution for really a big problem of the long infusion times, to give Daratumumab subcutaneously. And this is a study that was done in multiple myeloma and compared different dosages, 1200 milligram subcutaneously versus 1800 milligram subcutaneously as a flat dose in patients with multiple myeloma. And what we observed was that the 1800 flat dose subcutaneous infusion or injection had a similar pharmacokinetic as Dara infused 16 milligrams per kilogram IV. And what we also observed was that the overall response rate was as expected and compared with the IV infusion of Dara. I don't want to really go into too many details, but again, there were no grade 4 infusion-related reactions in the dosing group, and all the infusion-related reactions occurred during the first infusion within the first 4 hours. This is important because if you give the drug subcutaneously and you send the patient home, you don't want to have an infusion-related infection at home overnight. So I think this was very reassuring that the drug is kind of, can be given subcutaneously and it's relatively safe. Also in terms of the adverse event, that was expected and consistent with the profile in patients receiving Daratumumab IV. So in conclusion, it was shown that the subcutaneous administration was safe, effective. The 1800 milligram Daratumumab was chosen for further evaluation and for further use. The response rate was consistent with what we give when Daratumumab is given IV. And again, there was a low incidence of infusion-related reactions. So based on those promising data with Dara and also the fact that we can give Daratumumab subcutaneously, Janssen started a large phase 3 trial for newly diagnosed amyloid patients. Almost 400 patients will be randomized to either Cybor-D for 6 cycles or Cybor-D plus Daratumumab. I think this is probably a study that might lead to the change how we approach treatment for amyloidosis. The trial is ongoing, well accruing. We also put patients on the trial, and I'm very excited about this. But there is another CD38 antibody, and I would like to mention that the CD38 antibody Isatuximab is currently also in clinical trials, also for AL amyloidosis. There is a SWOG trial that was started and initiated by Emma Scott, who unfortunately left Oregon and went to somewhere else. Maybe she is here. We miss Emma at SWOG. So this clinical trial is a phase 2 trial for relapsed refractory patients with AL amyloidosis. And the inclusion criteria I mentioned already, they must have measurable disease with a lambda kappa light chain difference more than 4.5. And Isatuximab is given for the first month weekly and then later every other week. And patients will receive treatment for 2 years. This trial is open and also accruing, and I already started to put patients on this trial. What about other approaches? Do we have anything beyond CD38 antibody? We have elotuzumab. Elotuzumab is approved for multiple myeloma, and it's an antibody that works a little bit different than Daratumumab. It has a dual function. It binds to SLAMF7 directly on plasma cells and mediates antibody-dependent cytotoxicity, but it also binds to NK cells and induces immune stimulation and an indirect killing of the plasma cells. I mentioned already that elotuzumab is FDA approved for multiple myeloma based on a large clinical trial that was done under the leadership by Saga Loniel and published in the New England Journal of Medicine. You can see that the addition of elotuzumab to Len and Dex increased significantly the progression-free survival in patients with relapsed refractory multiple myeloma. And based on this, Dr. Sonder initiated a clinical trial with Revlimid, elotuzumab, and Revlimid, dexamethasone, elotuzumab, and randomized that versus lenalidomide, elotuzumab, dexamethasone, and cyclophosphamide. Patients receive also a maintenance treatment with Len, Dex, and Elo for altogether 2 years. This trial is ongoing. I'm not sure how many patients have been accrued to that trial, but I think we are excited to have an additional antibody, especially when Dara goes up front, to have something available for the relapse refractory situation. Something a little bit different, Dr. Girald from MSK initiated a clinical trial with an IL-6 antibody. Cetuximab is blocking IL-6, and he started a clinical trial to help cytokine-associated symptom burden after transplant to improve the quality of life and recovery immediate post-transplant. What he is doing, he is giving in a phase 2 study interleukin-6 antibody for patients who are between 60 and 75 years old and undergo autologous stem cell transplant. Patients receive that antibody twice, 1 hour infusion 7 days before the transplant, and again on day 21 after transplant. Completely different approach, but we will see whether this helps to relieve the symptoms, especially around transplant for patients with AL amyloidosis. IgM-associated AL amyloidosis is a little bit different. It's a rare clinical entity with some certain characteristics, but I would like to share some data from Dr. Palladini. He initiated a small trial with 10 patients of IgM AL amyloidosis. I'm not sure how long it took to get 10 patients with this rare disease, but he treated the patients with rituximab, bortezomib, and dexamethasone, and he saw nice response rates of 78% of the patients, including 3 patients who were refractory to Rituxan. He saw some grade 3 events in 3 patients, and what they concluded that the trial, or that this combination needs to be tested in a larger clinical trial. Maybe there's something what we can plan, after that meeting to move ahead. This is one of my last slides. This is not a monoclonal antibody. Ibrutinib is a kinase inhibitor and was tested also in patients with IgM-related AL amyloidosis, and the results were kind of disappointing, as you can see here. And please focus on the red and on the blue bar. Red is the free light chain difference at the start of the treatment, and in blue, the best response. You can see that there's almost no response, or not really very impressive response rate after the treatment as a best response, and there's even progression of disease under that treatment with Ibrutinib. And you can also see that the event-free survival and the overall survival was somehow disappointing. So Ibrutinib is really, I would say, not the strongest drug in IgM-related amyloidosis. So this summarizes what we do right now for AL amyloidosis, first line, second line, and also other treatments that help to increase outcome of patients with amyloidosis. And you can see that most likely we will integrate our monoclonal antibodies in the future up front. If I make an educated guess, I probably anticipate that the Dara addition to Cyborg might really improve the early response rate and will probably be the new standard for amyloidosis. But again, this is just kind of my personal opinion. Second line treatment, again, we will be, I'm very excited about the addition of elotuzumab to the already existing regimens, and second line daratumumab. I think this is what we are doing right now. Also, isatuximab, based on SWOG data, might be an option for second line treatment. So in summary, right now we have the most experience with monoclonal antibody with Daratumumab. It's well tolerated, very effective. The subcutaneous injection will reduce the infusion time and I think will make the treatment very convenient. The combination with CyBO-D is probably very promising and clinical trials are ongoing. We will see what the result is of other antibodies with isatuximab and elotuzumab, and we have to see if we are able to decrease really the light chains very early within the first months. Maybe we are able to overcome the still very high early mortality in those patients, but we need to prove that in clinical trial. And this is my last slide. I think those talks are always a good opportunity to thank the group that is behind you. I'm very happy to have especially a strong group, cardiology group under the leadership of Dr. Maura behind me, and also J. Radhakrishnan from nephrology. Our transplanter Marcus Mapara and pathology are really a tremendous help to kind of treat our patients each day in an appropriate manner. Thank you so much.
Thank you so much. That was an excellent presentation summarizing the available data on monoclonal antibodies. If you'd like, you can join us up here. We'll be answering questions, clinical questions and topical questions during the panel session.